Hi there, and welcome back to another COVID-19 update with Dr. Manfred Green, Director of the University of Haifa's International Master's Program in Public Health and Global Health Leadership, hosted, of course, by the American Society of the University of Haifa. Now, today we're going to be doing things a little differently to how we usually do it. Rather than going through the latest news developments around COVID-19, we're lucky enough to be getting an exclusive first-hand look inside some of the research going into COVID-19 as Dr. Green presents the latest findings of his very own research with us. Now, Dr. Green was one of the university's 18 faculty members to be presented with the Israeli Ministry of Science and Technology's funding to draft coronavirus-related research proposals, putting the University of Haifa at the forefront of research around the pandemic. So without further ado, I'm delighted to open the floor up to Dr. Green to present his findings of basically the public's openness to vaccinations, which is something that is obviously very applicable to right now and relevant. After which we'll go through a few questions related to the research and vaccinations in general. So with that, Dr. Green, over to you.
Thanks very much, James, and it's very nice to be with you again. I'm going to present some findings, and I stress that we're doing preliminary analyses. We've completed 2 surveys, basically on the attitudes of the public or the knowledge of the public about COVID-19 and other aspects of it. A number of them are related to trust and so on, but in the authorities. But one particular one that we've been analyzing is the issue of the vaccine and the willingness to actually take the vaccine or not. So I'll give you some initial data so that you can get an idea of where we are. So the second survey that we carried out, there was 2 surveys, but the second one dealt specifically with aspects of the vaccine, in addition to a number of other issues. So we interviewed through a panel survey. So we did a panel survey of 800 adults over the age of 18. 600 were from the Jewish population and 200 from the Arab population. And they completed the questionnaires, which actually had about 40 questions. But I'll focus just on the vaccine side. Interestingly enough, if you look at the willingness to accept the vaccine among the men, only 27% of the Jewish population and 22% of the Arab men indicated that they would like to receive one of the vaccines as soon as it became available, right? So that means that in this, at least in this initial data, it was something like not just around about a quarter of the population of men who said that they would be prepared to receive the vaccine as soon as it became available. But very interesting, among women, only 14% of Jewish women and only 9% of Arab women said that they would like to take the vaccine as soon as it became available. So that's really, I think, really interesting and surprising. We have other questions which said that they would take the vaccine after it had been extensively used. And in other words, it had been used in thousands of people or for a long period of time. But when we looked at the differences also in terms of whether they would receive the vaccine at all, only about 8% of Jewish men said that they would refuse the vaccine under any circumstances. But in the Arab population, 32% of the Arab men said that they would refuse vaccination under any circumstances, and basically not trusting the vaccination. And among women, 17% of Jewish women said they won't accept the vaccine under any circumstances, and 41% of Arab women who said that they weren't prepared to accept the vaccine. Now, this is, in other words, they would not be prepared to be vaccinated. This is actually very interesting because generally in the Arab population, the vaccination rates, immunization rates are very high in children. In fact, higher than in the Jewish population. But I know for influenza vaccine, it actually seems to be the reverse. So in adults, in the Arab population, there's less willingness to receive some of the adult vaccines. It's still high, relatively high, but much lower than in the Jewish population. But interestingly, here, there appears to be a lot of lack of trust particularly among the Arab population. I would say there's a lack of trust in the whole population. but there's in a large part of the whole population, but particularly in the Arab population. And that's it's a very important issue, because we're going to have to deal with it not only on the population level, but we have to deal with it also in subgroups. About 31% of Jewish males and about 70% of Arab males said that they would receive the vaccine after thousands of people had been vaccinated. And among women, the numbers were 28% would get it after thousands have been vaccinated, and 16% of Arab women said they would get it after thousands have been vaccinated. But I go back again to the two very important points, and I'll just repeat them once again, that 27% of Jewish men and 22% of Arab women said they would only they would like to receive it as soon as it's available, and only 14% of Jewish women and 9% of Arab women. So that, if that's true, and we have to carry on with these analyses, and nothing is done to change this, that means that we'll be in the interesting situation where we'll have vaccine doses available, but we may not have the kind of demand that we thought we would have. Of course, this hasn't been broken down into age groups, so that might be affected as well, because initially, at least under current recommendations, probably the elderly and the health workers will receive it first. So the numbers may well be different in those subpopulations. But I think that this is a warning light, a warning signal that we may certainly have some problem with what we would call acceptance of vaccination, and this issue of what's called vaccination hesitancy, which basically means that people are suspicious of receiving vaccines.
Right. Right. And what do you put that suspicion and reluctance down to? Is it obviously there's been a lot of negative connotations with the pandemic in general, and there's been misinformation, various lockdowns, and not knowing what exactly, back and forth as well from the government, I should add. Has all of that contributed to public reluctance and an unknowing reluctance to take this vaccine, and what is the reason for this?
Well, I think there are two things, and I think we probably, when we were talking in the past about vaccinations, we didn't really think far ahead. We've pretty much put a message through to the public that vaccines take a long time to produce, years basically. We often quote 6, 8, 10 years to produce vaccines. Sometimes a little quicker. So already there's a big question mark in the public saying, well, if that's the case, how is it that in this circumstance, they were produced so quickly? I mean, months, then you have to explain that a lot of these technologies were available and in development previously, so it wasn't just something that started from scratch, basically, particularly for the SARS vaccines and so on, the SARS of 2003. So there was already work being done to produce vaccines. So it's not something that sort of came out of the blue. But it does say to the public, wait a second, hasn't this been going too fast? Because we're told that vaccines have to be tested, they have to be tried, proven to be safe and effective. The other point, and one issue is that I feel that the companies, the way in which the companies are releasing their results is not a good way to get a message to the public. They're giving very initial data without details, and even the people who are professionals and who work in the vaccine field, and I count myself among them, have difficulty explaining to people what these messages mean when we don't have any real information. All we know is that it was 90% effective, 94% effective. We know how many cases there were. In 1 or 2 occasions, we had to work out how many there were in each group because that wasn't immediately published. We don't know much about the statistical analyses. So it's been very difficult, even for professionals, to interpret these messages. And I think the last point, and I've said it before, and I'll say it again, I think the right thing for the companies to do is to first publish their findings in a journal. They can do that quickly, and there's no problem getting a journal to publish their findings very quickly, within days, basically.
So I do want to touch on the point you just mentioned there about companies releasing the findings of their initial results. I mean, the past week alone, we've had announcements from Pfizer, Moderna, AstraZeneca just recently on successful clinical trials. Does this mean we're close to having a vaccine ready? And what does it mean when the likes of Moderna and Pfizer are releasing effectiveness around the 95% level, and then at the same time you've got AstraZeneca around the 70% level? Does that mean that's not as good as the other two vaccines? And what should we make of these figures?
Well, at least for the companies such as Moderna and Pfizer and also AstraZeneca, as I understand, and I must be honest, I haven't seen their publications, although they have published earlier on the study design and so on. So it's not that they haven't registered their studies, they've registered their studies, so the data is available. And they're going through an acceptable path of it. So it's under basically a regulatory body, whether it either be the FDA in the United States or the European Regulatory Councils. So in fact, it is monitored and it is going through regulation. So I'm not concerned that in fact there wouldn't be the kind of safety measures that should be in place. I think I'm fairly confident, or very confident, that the safety measures are put in place. Mm-hmm. I think that they have to be careful about what they're saying about the efficacy, because it's early days. As you know, all of these are initial preliminary data based on relatively small amounts of cases. So we might find this change, and certainly when you look at much older people, that may change substantially. One maybe a little, some may say unfair comment, but I might comment on the AstraZeneca trial. They say that it's been shown to be safe and effective in people over the age of 70. Well, for me, over the age of 70 includes people 80 years old and 90 years old, when in fact, the people in their trial were set between ages 70 and 74. Uh-huh. So that was what they meant when they said over the age of 70. At least that's what I've seen. If they come to me and say later they have other data, well, that's okay, but then where is it? Because that's what I found, and that's what's been published. So again, I think that the companies are doing us a disservice by the way that they're presenting their findings. I don't think that they're not doing what should be done, but I don't think that they're publishing it in the way. And that comes back to what you asked. How do we get the public to be receptive to these vaccines? We have to be extra careful that everything is super transparent, that everything is out in the open, and that everything is published. And we really don't have to rush. The rush is not hours and not days. We're going to be with us for a long time. By the way, it's going to take us a long time anyway to vaccinate. So if we wait another week or another 2 weeks to get it published, that's what we should be doing.
Right. Right. And then I guess supposing, they are able to roll out the vaccine and, hopefully public perception maybe changes about the vaccine and the willingness to take it. How long will a vaccine for? Is this going to be something like the flu shot that we have to do yearly?
Well, this is something we don't know. So, it's a kind of wait and see. The annual flu shot is not so much because of a decline in the antibodies, although there is a decline. It's more related also to the change in the actual antigen in the virus, because the influenza virus actually tends to change fairly rapidly. So we have, each year we may have a different strain that's slightly different from the previous year, and then the previous vaccine's not that good. That's not, so far that's not the case with COVID-19. So far we've seen there is mutation, but the mutations haven't been related really to the impact on the vaccine. So the good news that it seems to be stable. It's actually, in some senses, it's a simpler virus than the influenza virus. So it's actually, in that sense, more stable, and we don't have to worry that much about a change, although we're monitoring it. The other thing, of course, is you may ask, though, is what about the strength of the antibody response? Let me just give you a very quick example. We vaccinate against mumps and measles, and we know that although those are good vaccines, particularly the measles vaccine, there is a waning of immunity. It's not very rapid, but it does occur over time. And then you do have cases of people who've been vaccinated not only once, but even twice, who then get infected. So for example, in the last epidemic of measles in Israel, there were not a high number, but there were a number of people who'd been vaccinated twice and actually became ill with measles. So again, we have to make sure now that we are monitoring very carefully the antibody status. I think I'm going to just say one sentence, which probably is not a good thing to say towards the end of the interview, but there are some reports of reinfection. So far, it's not been common, but it has been occurring, and it seems to be well documented. So that's an indication that, in fact, either the antibody response declines or the antibody levels decline and are not over. And maybe if you're exposed to a large amount of virus, then you may, even though you've been exposed previously or been vaccinated, you may actually get the disease. So on the whole, though, we need to be optimistic. I mean, these vaccines certainly are a breakthrough, and this is certainly going to make a big difference in handling the pandemic.
Right. Right. Final question I had, because I see that we're running tight on time again, is looking more forward, I guess. What is there anything, I guess, being done to plan for the distribution of a COVID-19 vaccine? Within that, who should be vaccinated first? And then even further, how is it being made accessible to countries around the world? I know that Israel have already announced that they have plans to buy a significant amount of vaccines from Pfizer. We've been hearing how the US maybe have plans in place. How are other countries around the world that maybe don't have the financial security that the likes of Israel and the US do? How are they getting their hands on the vaccine?
Well, Israel is a small country and well organized in terms of immunizations, because we've got this network of baby clinics who do immunization of babies, and we have the general health fund clinics and so on. So in terms of the logistics, we are well poised, and it's now being boosted by all kinds of supplementary, shall we say, personnel and logistics. So we could basically vaccinate a lot of people in a pretty short period of time. There is one slight catch that we have to remember. Some of these vaccines require 2 doses. So in other words, you have to vaccinate the person twice. Mm-hmm. And a 2-dose vaccine is always, as you can imagine, logistically much more difficult, because people either don't come back or they forget, or you have to find them. So getting them to get the 2nd dose is not going to be that easy. We know it for hepatitis A and hepatitis B and so on. The 1st dose is easy, the 2nd dose more difficult, and it drops, and you have to chase people for those. Yeah. So we're going to have to deal with that issue, and that's certainly going to be something that's going to be tackled in. So I would say we're in for a period where the vaccination program will go over a period of months. And basically, we'll just try and get, as many of what we would call the high risk, or I would say also those who are the transmitters of the disease, vaccinated as much as possible. And that's another tool in slowing down the spread. But if you say to me, we can stop the restrictions and so on, well, I would certainly say it will stop many of the restrictions, but the usual masks and not social distancing and so on, those are the things that you have to we'll have to continue them, maybe at another level. Hopefully we'll be able to open schools and have shops open and things like that. So, but people will still have to be careful.
Right. Well, it's with great reluctance that I say that we've come to the end of our time once again. Dr. Green, thank you so much for sharing your research with us today.
Pleasure.
It's been fascinating, and I think I speak for everyone that's been tuning in today, to be given an insight into what goes into the science behind fighting a vaccine like this, a virus like this. As always, if you have any questions for Dr. Green, please do leave them in the comments section of this video, or email them please to info@asuh.org. We'll be happy to look at those and even address them on the next briefing that we have with Dr. Green. For more information about the university's ongoing work around the pandemic and support the university during this time, please also find a link included in this post. Thank you all very much.
Thank you very much, James. I just want to mention that the studies are funded by the Ministry of Science. Thank you.
Thank you, Dr. Green.